Good morning, everyone. I'm Dr. Carmen Pugliafito, and I'm here today with Dr. Veeral Sheth, who is with University Retina in Chicago and is an assistant clinical professor at University of Illinois at Chicago. Veeral, good morning.
Good morning, Carmen. Thanks for having me on today.
Welcome to Retina Synthesis. Today, we're going to talk about the Altissimo trial from Graybug. And why don't you tell us about the design of the trial and what the biology of this therapeutic system is?
Yeah, so I'll answer that second question first. What are we studying in the Altissimo study? We're looking at a molecule called GB102, also known as sunitinib, and that's a TKI. So we're looking at something that is able to kind of suppress VEGF in a pan VEGF suppression mechanism of action. And so not just VEGF-A like we're used to with our current standard of care, but also the other VEGF isomers. And so the other kind of unique aspect to this molecule is that it's basically embedded in a molecule that's released over time, right? And so I think the two things we're looking for today are, advanced mechanisms of action, but also durability. And so that's kind of the angle of this GB102 molecule. So the trial itself, we're looking at patients that have been previously treated for wet macular degeneration, had to have had at least 3 anti-VEGF injections prior to enrollment in this study. And so for those patients that were enrolled, there were 2 study groups, a 1 milligram GB102 group and a 2 milligram group. And those patients were dosed at day 1 and then again 6 months later with the GB102 molecule. And they were compared to the aflibercept group that were getting Q8 week aflibercept. So we looked at those 3 groups, and I will say during an interim analysis, because of some of the safety signals, the 2 milligram group of the GB102 was dropped. And so those patients that stayed on in the study were converted over to a 1 milligram group at their second dosing. So that's kind of the gist of the trial. It was a 12-month study. And for patients that didn't need rescue therapy, they were able to continue on into a 6-month observation. And so 28 of those patients were continued on out of the total cohort. And so we got to see what happened to those patients 6 months after the core study ended, and to see how long they could go without rescue therapy.
What was the rescue criteria?
Yeah, so rescue criteria were a drop in 10 letters or an increase in CST of 75 microns or more. So, it's interesting, right? Because we did see in this study that patients were rescued despite having no CST worsening. And so why is that, right? They did drop vision. Well, why did they drop vision? We did see patients in this study where the drug was dispersed. And so you got these vitreous floaters. That was one of the most common adverse events that we saw. And these floaters, especially 3 months after the injection. So you saw it at month 3 and then again at month 9, which is 3 months after their second dose, where these floaters would disperse, the drug would disperse and the vision would drop, and you would see patients get rescued because of that vision drop. But if you actually went back and looked at their CSTs, they probably didn't need a rescue, and the vision drop was really kind of transient from the floater. So those were the rescue criteria. And maybe how, if you think about that, how these could be fine-tuned for this particular drug in the future.
How many eyes were in the study?
Yeah, there were 56 patients in the study.
Divided equally between the 3 groups?
Yeah, so equally between the 3 groups. And then again, like I said, that 2 milligram group continued on, but at a 1 milligram dosing for the second interval.
So it wasn't a huge study.
No, small phase 2 study.
And what happened to the visual acuity at 52 weeks?
Yeah, so there's two really primary endpoints to this was change in baseline BCVA and change in baseline CST. And CST was pretty much on par between the study groups and the aflibercept groups, but BCVA was lower in the ultimately what became the 1 milligram study group. And if you look at it, if you break it down and look at each individual patient, most of them from a BCVA standpoint clustered around the aflibercept group, but there were 4 outliers that really drove kind of the BCVA discrepancies that we saw. So there were the 4 patients, you know, one of them had a subretinal hemorrhage and never recovered that BCVA fully. That subretinal hemorrhage happened about 3 months after the treatment with GB102. And then the other 3 patients, when you look back, were pretty high need anti-VEGF therapy patients. So ahead of the enrollment, they were getting real frequent injections, and you can argue that they really never dried out before enrollment into the study. And so, you know, it begs the question of patient selection, you know, maybe a broader discussion about TKIs in general and where they fit. You know, is going with a more durable model, is that good for patients in the long run? Do we need to get them dried out before we convert them over to something like this? So there's so many questions that we kind of have coming up from these. And it's something definitely we can dive into if you're interested.
So the durability data was exciting. Can you talk about that?
Yeah. So we saw that, you know, in the durability group, what are we looking for? These are patients that were dosed every 6 months, essentially. And so we saw that 81% of the patients achieved 3 months or more durability. In other words, they were able to go 3 months before they needed a rescue therapy. 48% achieved 6 months or longer, and 29% achieved 12 months durability. And so, you know, that's kind of, it's exciting, right? Because right now we're talking about 6-month treatment platforms that are surgical. And so to be able to do this with an intravitreal injection is pretty exciting. I think if you looked at durability from the standpoint of injection frequency, you also saw what you wanted to see there, which is a 63% decrease in the injection frequency. So you had patients coming in prior to enrollment getting about 10.5 injections per year, and then on study, once receiving the GB102, getting 3.5 injections per year. So you like to see that as well if you're looking for durability.
What's the delivery system like?
Yeah, so there's I think there's 2 ways that I look at it. There's one is the preparation of the medication, which is, you know, there's an 11-step preparation process. So Graybug is working on simplifying that, and probably will cut the number of steps in half as we move forward with newer protocols. But, you know, it's a compound that you've got to prepare. You've got to really make sure you know, that it's mixed properly, because you can get potentially some of the powder that's not completely dissolved from the solution, and so that can be an issue. So once you get it the proper consistency, it's a pretty thick compound that you've got to inject through a 27 gauge needle, but you can do this via an intravitreal delivery. And so it's not like some of the other TKIs that are in it, like a Duracert. It's actually just a molecular compound that ultimately dissolves completely in the end.
Where does it sink into the lower vitreous?
Yeah, great question. So this is given, really you want to inject at right about 6 o'clock. So it's unlike kind of I do my other injections supratemporally, but this one you're going right at 6, and you're essentially delivering it into the kind of the inferior space there, and it just sits there. And theoretically, it should kind of release over the next 6 months.
So what's the next step for this product?
So they're working on enhancing the molecular compound itself. So the key is, you know, as we discussed a little bit, the issue with some of these patients was dispersion of the molecular compound. That dispersion can lead to floaters. That floaters can lead to some transient drop in vision. So they're working on making a little bit more of a cohesive molecular compound, so that it's not messing with the kinetics, in the sense that it'll still release over the course of 6 months, but it won't disperse and create as many of these floaters, which can affect the vision as well.
Well, what percent of eyes had dispersion that was notable?
Yeah, there were about 5 patients in the GB102 1 milligram group that had this. So we're not talking about a huge percent, but enough where in a small group it made a big impact.
Well, this is fascinating. Do you think TKIs have a future in retina?
Yeah, it's a great question. You know, so there were 3 really good presentations at Angiogenesis, and I think for me personally, I saw a pattern, right? I think that you saw that there is a subset of patients that do really, really well with these TKIs. In other words, if you look at, Dr. Duker's and Dr. Moshfeghi's data that they presented at angiogenesis, we're talking about half, maybe 60% of these patients that can get a dose of these medications and then not need anything for 6 months or maybe longer. I mean, we saw patients, about 30% of our patients in the 1 milligram group, that didn't need any rescue therapy for a year. So if you look at just that, my easy answer is, yeah, there's value there for sure. The question really is, why did we have some of these outlier patients, right? I told you about 4 patients in our group that really drove the BCVA down. So who were those patients? How do we figure out, how to identify the right candidates for these medications? And if we can do that, I think that there's really kind of room for this in our toolbox.
Well, I think you got unlucky with those 4 patients.
Yeah. Well, and look, I think that speaks to kind of future study design and making sure patients are stable, dry before you put them into a study group where they're receiving a drug that may not hit those same kind of bolus levels of therapeutic in the eye, but are enough to maintain a dry retina over time, right? So I think that was kind of one of the learning lessons of this study.
And they didn't have a mandatory pre-study injection of aflibercept.
They did. Theoretically, they were supposed to receive a study drug injection 3 weeks prior to their first study drug. In other words, an anti-VEGF injection prior to their first study drug injection.
So they did do that.
They did, but there was no, I think now newer studies are looking at, okay, well, when they get this, what is the initial treatment response to the anti-VEGF, right? Making sure that they do dry out with the anti-VEGF therapy before they enroll the patient. I think that's a really good way to enroll these patients into these studies, where you're not getting high levels of potentially drug, but you're getting nice, consistent levels of drug.
Yeah, I agree with that. I think that the TKI as a durability agent works best when the eyes that start are totally dry.
Yeah. So I mean, I think, Carmen, the real question is this a mechanism of action that has legs? And I think that my answer is yes. And I think as we get these newer agents, I mean, look, we've got the recent approval of faricimab. We've got all these new agents, newer mechanisms we're looking at. I think we're going to have to be a little bit more particular in how we select patients and which medication we use to kind of tailor their care. So I think again, I think there's a place for this. I think we're just at the beginning of these phase 1, phase 2 studies where we're figuring out who it's right for and who it may not be right for.
Well, Veeral, this has been an interesting discussion, and we need to check in later
Thanks,
about Graybug.
I appreciate it. Appreciate your time.